So I participated to this large conference as invited speaker, and the first of my presentations was about the tailoring of radiation therapy in the 21st century, and of course, related to breast cancer, as this is my topic of interest. So while for medical oncology, we have already a lot of applications for individualizing treatment based on molecular or genomic subtypes, much less is the case in surgical and radiation oncology. We have some indicators, for example, adapting the treatment based on molecular subtypes for radiation therapy. While especially medical oncology, molecular and genomic subtypes are already broadly used to individualize treatments, much less is the case in surgical and radiation oncology. However, we have several clues that it could be very useful. For example, the molecular subtypes known as luminal A, luminal B, triple negative, and HER2 are demonstrated to have a differential impact on the role of radiation therapy in preventing locoregional recurrences and in improving survival, like breast cancer specific and overall survival. So in general, luminal A breast cancer has low locoregional recurrence rates and good outcomes, while radiation therapy given in the past reduced also in HER2 types and in triple negatives locoregional recurrences, but had much less impact on overall disease-free survival and overall survival. This could be explained by the much less active systemic therapies that were available at the time. So looking in more recent, more contemporary series, we can see that postoperative radiation therapy has a relatively less important impact on locoregional recurrences, because we see even without radiation therapy less local recurrences, but proportionally a bigger impact on overall survival, because distant metastases are more effectively treated by HER2-directed systemic therapy and by effective systemic therapy, chemotherapy for triple negative tumors. Genomic signatures, like for example the MammaPrint or Oncotype DX, are also tested in old prospective trials, but run mainly in the 1990s and some in the early 2000s, and have been shown to also have a predictive value on the occurrence of locoregional recurrences, and in some of the studies also to have a value in predicting the benefit of radiation therapy. So it is very likely that both molecular subtypes as well as genomic profiles can be used to select, on the one hand, the patients that have already a very low local recurrence rate or any recurrence rate even without radiation therapy, and then for the other patients to identify the patients that have most benefit of postoperative radiation therapy. A very interesting approach is GARD, which is the genome-based model for adjusting radiation therapy dose. So this signature discriminates patients who have a high GARD and thereby a higher rate of distant metastasis-free survival, and a low GARD who have a higher rate of distant metastasis. I restart from GARD on. An interesting approach, more recent, is GARD. GARD is a genomically adjusted radiation dose. And this predictive test discriminates between patients who have a high GARD and a lower rate of distant metastasis, and a low GORD and a higher rate of distant metastasis. This predictive factor worked in several subsets of cancer cohorts, including breast cancer cohorts, and as such had a stronger predictive factor than the radiation dose itself. So it could enable us to predict the required dose of radiation that we need to effectively prevent recurrences. And as such, if we look at the dose that we require to obtain tumor control next to the dose that could cause late normal tissue effects, we can hopefully in the future use a signature like GORD to predict which patients are sensitive for tumor and for late normal tissues, and thereby require a lower dose of radiation. Other patients that have a high resistance for tumors, for late normal tissues, and might not benefit from radiation or need a high radiation dose. And then the ideal patients who have sensitive tumors and resistant normal tissues, the patients where the therapeutic window in between to obtain tumor-free control might be largest. If we look to all those data and compile them into a time schedule, we can globally say that in the 1980s, radiation therapy had only a very important benefit for the patients who had low risk features, either with an early stage disease or patients who had a low risk profile, for example, luminal A breast cancer patients. The patients who had aggressive tumor types, they had the issue with distant metastasis, which could not be prevented by radiation therapy because they were already present at the time of treatment. With improving effectiveness of systemic therapy, we see that the proportional benefit of local regional treatments, surgery, and radiation therapy became gradually bigger. And now, with even more effective systemic therapy, we have patients that have already very low recurrence risks, even without radiation. So it might be that we can further de-escalate the indications for radiation therapy, or maybe some patients also de-escalate systemic therapies. And of course, thanks to screening, we also see more and more very early stage disease patients which require less systemic therapy and benefit optimally from radiation and surgical treatments. Individualizing radiation therapy is not only about yes or no prescribing radiation therapy, it's also about the dose. It's about the number of target volumes, and it is about the size of the target volumes. For example, the last one, very traditional. In many patients, we don't need to give any more radiation to the entire breast, but we can give partial breast irradiation. So, in conclusion, in the near future, we will be using much more molecular and genomic profiling to tailor individually our radiation prescription for every single patient. We know a lot about what are the predictive factors and the prognostic factors, but they interact also with tumor stage, with patient-related factors, and very important, with the interaction with systemic therapy. And the latter varies a lot over time. And that's why my key message is breast cancer treatment is a multidisciplinary effort. Treatments could be mutually exchangeable. Look at low risk or high risk early stage disease, where we could optimally balance the amount of systemic therapy and the amount of local treatment. Look also at the approach of the axilla. De-escalation, there is a place, but it should go step by step, and we need to take into account several endpoints. For example, local regional control as sole endpoint for surgery and radiation therapy is absolutely insufficient. Having said that, I think I would like to conclude because this was the most important of my contributions. The other were debates and some more educational sessions for the radiation oncologist. Thank you very much for the attention.